dental practice in 2007 and has served as the Canadian Dental Association's leading expert in eco-friendly dentistry, nutrition, and wellness. He is one of the first dentists in Canada to place all ceramic dental implants and has developed one of the largest implant practices in Canada. His office focuses on nutrition, metal-free options, soft and hard tissue regeneration, and neuromuscular full-mouth rehabilitation. He recently completed a program in Austria and Switzerland at the Integrative Health Clinic in Celsius, where he is now a dental advisor. So please help me in welcoming Dr. Ali Farahani.
Thanks, Dave. Friends, just before we get into the heart of the lecture, for those who are new to the Academy, I just wanted to say a couple of words, about the Academy at the risk of cutting into my lecture a little bit. I'll stay, a lot of material to cover, I'll stay afterwards, or maybe cut a little bit into the break, and I'm happy to answer any questions, but I just want to say a little bit about the Academy for those who are new. And in 2008, I had the privilege of speaking to the Academy about eco-friendly dentistry, and I was so really moved by the Academy that, we all have different memberships in different groups and organizations, ortho, implant, this and that, but how many of them have an actual environmental committee, right? And look around today. Here, all our speakers are speaking about healthy living, healthy dentistry, and look at the snacks that we have, right? They're not the typical, right? You don't see croissants and muffins and all the usual junk that we get at all the other courses. So this is an academy that walks the walk, and I'm just deeply privileged to be a part of it and to share some thoughts with you about the academy, about this topic today. So the topic is Physiological Reconstruction for the Biological Dental Practice, and I added a subtitle, In Search of Oxygen. Dr. Hindon had an outstanding presentation this morning about, heart rate variability and oxygen, and there are no less than, I think, 2 or 3 other lectures, whether in breakout or in plenary, about oxygen and physiological dentistry. So this is a key topic for us. So as a disclaimer, I have no financial ties to any CE Institute. I have no conflict of interest. And my journey as a clinician, I've been on an occlusal pilgrimage for about the past 15 years, and this presentation is a result of that. So it's really a survey of dental occlusion through my eyes. So I'm not suggesting that there's a right or wrong way. As far as I know, there are no studies available to compare all the different occlusal philosophies. So again, let's have some fun with this. This presentation has ended to be a flyover. Occlusion is often called a religion. I don't want to get into religious warfare or occlusal warfare with anybody. Let's have some fun with this and just have a walkthrough. We're all dentists. We're all, able to determine in our own practices what's best for our patients and best for our practices. So please don't take anything I say as suggestive of the best. Of course, I have my own bias. I'm very, as you'll see, but it's not to say that there's one way that's better. I have a mentorship program. If I have time, I'll mention that a little bit. So, by way of outline, I've broken up the different occlusal philosophies into joint and teeth-centric philosophies. So these would, of course, include Dawson, Pankey, and I put in brackets my clinical experience with these different philosophies. So I have several full mouth cases with Pankey, a spear as well. Coys, I spent 5 days, intense days with Dr. Coys this past May, studying nothing but occlusion and functional approaches to dentistry. So that's very fresh in my mind. And the second large, area is muscle-centric philosophies based on occlusion, and this would include neuromuscular. Within neuromuscular, there are many, individual schools and things you can do. And so the one I'm most familiar with, although I'm familiar with many of them, is LVI, and I have over 100 of those cases in the mouth. We'll talk a little bit about method mentorship. So let's get into it. So muscle and joint and teeth centric. Dawson, number 1. So Dr. Dawson talks about the 10 factors of occlusion, and for him, number 1, the TMJ, he calls it the starting point of pain. He calls CR the single most important thing you have to know as a dentist. It also is known as the back end. He does talk about the role of muscle. He mentions anterior guidance as the second most important, otherwise known as the front end, and he calls it the key to the stability of the occlusion. So these are his 10 factors. He discusses, of course, vertical dimension, neutral zone, the envelope of function, and he says this is defined in the mouth, not on the articulator, which is actually a very interesting statement, as we'll see, a little bit later on. There's this concept of long centric, where he says 50% of the people need it, 50% of the people don't need it. The occlusal plane, of course, is an important concept in Dawson. And finally, of course, the occlusal contacts. So these are just sort of the 10 main tenets of the Dawson occlusion. This will be familiar to most of us, as we would have been exposed to, some of this, of course, at least some of this in our dental school, if not afterwards, if you've taken the Dawson Institute. The next major joint and teeth philosophy is the LD Pankey Institute. And of course they have many courses, and this course, E3, is what you would call their full mouth course. So it's called the Integrating Aesthetic Occlusion and Restorative Principles. This is where they would teach their students, teach dentists how to do the full mouth. And the concepts that Pankey thinks are very important is, of course, the CR record, right? FACEBO. There's a big emphasis on the semi-adjustable articulator. And it's about understanding the determinants of occlusions. Again, anterior guidance comes back. We hear some echoing of Dawson. Again, it's equilibration is another key concept. Joint stability. These are all key concepts or tenets under the Pankey Institute. Of course, it's always important how you prep a tooth, and making beautiful provisionals is very important. Communication with your lab. The envelope of function, envelope of parafunction, actually is again a very interesting concept. That there's this notion of an envelope of function, envelope of parafunction, which is not defined on the articulator. And I'm making a distinction to that because we'll come back and talk about articulators. What I found particularly interesting as I was looking through Pankey was that there's a great emphasis here. I'll just read this from, they say, as the guardians of fee-for-service comprehensive care dentistry, we're committed to offering the next generation the opportunity to discover the benefits of a Pankey education. Please put your hand on the rope and join us to help ensure that Pankey will transform dentistry in the next 50 years as profoundly as it has in the last. So undoubtedly with Pankey, it was very, very clear to me that there was a great deal of emphasis on community, on joining hands as dentists to fight against the forces that are taking away our freedom, our liberties to practice dentistry. I think this is very wonderful. It's very laudable. It was very, very palpable when you look at Pankey. So I think that's a wonderful thing. Moving on to Spear, we see that there's this Spear. It gets sort of much more narrowed now. The focus is a little bit like a microscope. Things are just becoming much more clear. The etiology of tooth wear, not clear, but more, the resolution is improved. The details are becoming more crisp. And by that I mean, in my own mind, when I went through this, I thought, okay, the etiology of tooth wear, patterns of wear, treatment plans are derived, from a lot, in part from this, from patterns of wear, etiologies of wear. It's very, very sort of specific. The tooth position, gingival levels, papilla levels, these are all important aspects of determining treatment options, for our patients in the Spear philosophy. Okay, vertical dimension, of course, is an important concept. And any occlusal philosophy has to have a good systematic and simple step-by-step approach for us. Dentists, we love systems and predictability, and give me a list. Tell me how to do this. It was very important. Orthodontic surgery, and as well as other modalities like ortho and perio surgery, are also discussed, extensively in complicated treatment plans. And material choice. So, there's sort of like a correlation between wear and material choice in the Spear philosophy. You have this kind of wear. You're looking at this type of material choice for your restorations, and we'll contrast this a little bit later on as we go through. So that's in a nutshell. So there's a lot of, with Pankey and Dawson Institute, with Dawson and Pankey and Spear, there's a fair bit of talk about, I'm getting a thumbs, good from my position is good. A lot of discussion about where the condyle is in CR. And so the question I asked myself as well, where's the condyle supposed to be? Centric relation, as we know, is, this, from a journal here, is the most controversial concept in dentistry. The concept of CR emerged due to the search for a reproducible mandibular position. There are over 26 definitions of CR since this term was invented. And so it is confirmed that there still exists no consensus about the definition as the latest definition for CR. And so I asked myself, where's the condyle supposed to be? And as a clinician, I'm not sure. I don't know how many of you know Dr. Farahani and Dr. Paul Homley. They're giants in our profession. Dental Town, everybody know Dental Town is has the most number of dentists worldwide belong to the one community of Dental Town. Howard Farahani, Dr. Farahani on the left, he's the founder of that. Dr. Homley is the giant of case acceptance in dentistry. And so they had a podcast recently, I checked it out, and they had a lot of fun, and I'll just let you listen into a clip of this and see what they think about where CR is or where the joint's supposed to be.
I gotta credit my homies. I'll tell you that if they went to 10 different occlusions on TMJ centers, right, they're going to get 10 different theories on TMJ. There's how many camps of occlusion? How many times has the condyle moved since we graduated from dental school?
It moves every year.
It moves every year. So
I can tell you.
Okay, so it moves every year. I thought that was particularly appropriate. So in terms of Koi's philosophy, this is where things start to change a little bit. As I noticed that the journey of occlusion now starts to come outside of the mouth. There's diagnosing occlusal problems. A big part of that is done via the deprogrammer. And Dr. Kois has his classifications of diagnosis of occlusal problems. Of course, there's acceptable function, aberrant envelopes, constricted dysfunction. But now there's something else. There's brain-initiated. So, prayer function, neurological disorders. The journey is now going outside the mouth. The conversation is changing now. We're no longer so focused in on teeth and teeth wear and gums. And so the conversation is changing. But as I was sitting there, absorbed in this discussion of occlusion with Dr. Kois, the deprogrammer, which is the key to his diagnosis for occlusion, I asked myself, I said, well, what are we deprogramming? Are we deprogramming a condyle? Can you deprogram bone? Are we deprogramming teeth? Are we deprogramming muscles? What, in fact, are we deprogramming with this world-famous deprogrammer? So my question to myself and here my colleagues, I ask you, besides joint position and vertical dimension, incisal display, occlusal plane, all of which are important, besides those, what other criteria could we as biological dentists measure or be concerned with when rehabilitating our patients? I would propose oxygen. This is, Harry Houdini in his famous glass chamber where he would be lowered into this chamber and he'd be locked up and he's all bound and gagged and he had minutes of course to get out or else he would die. And infamously he had one occasion where he couldn't get out, and these gentlemen here are not just performers, they actually are there to save his life, and they had to save his life. They had to break the glass and let him out or else he would have died. Why I put this particular picture in here, besides relating it to oxygen, is because I asked myself this. I saw my patients when I had sedated patients, and I didn't know they had sleep apnea because they didn't know they had sleep apnea. I saw them do the craziest things to their teeth when they had an apneic event. mean, to my distress, because I'm trying to do some, implants or something on the, and so I saw them do craziest things with their jaws and with their teeth, and it was nothing. There was no pattern of it was most random destruction pattern you could imagine. And I asked myself, well, what would I do if I was starved for oxygen? If I needed to get out of oxygen? If I needed oxygen? And the answer that just came to my mind is anything. I would literally do anything to get oxygen. So that's what Harry Houdini or anybody who's trapped, we would do anything. So when an organism is trapped for oxygen, they literally do anything to get more oxygen. So besides the obvious life and death needs of oxygen, what evidence do we have that oxygen is what I'm just loosely calling the king nutrient? What evidence do we have? Well, turns out we have a fair bit of evidence. Oxygen is one of the critically defining elements resulting in the existence of eukaryotic life on this planet. I won't read the whole thing, but the evolution of multicellular organisms and their occlusions, I may have just added that in, and the regulation of complex cell phenotypes. So by understanding these events, we can plot the effect of oxygen on evolution and its direct influence on the direct forms of life today. So oxygen has formed and shaped life more than probably any other nutrient, more than maybe sunlight, more than calcium, more than magnesium, more than any other nutrient. Oxygen has changed organisms over time. So for that reason, I'm calling it sort of the king nutrient. So if oxygen is the king, my question to myself, as my question I asked you, is how much oxygen does the condyle need to function properly? This is Dawson and Pankey's main tenet. The condyle. How much oxygen does incisal guidance need in tooth position? Gingival levels, papilla levels need to function properly. You understand this is a tongue-in-cheek question, of course, but this is a Spear main tenet. How much oxygen do these things need? How much oxygen does a deprogrammer afford the individual? Well, now that's starting to make more sense to me. I can see that with a deprogrammer, this could afford an organism called our patient more oxygen. So the conversation starts to change. And so, is there a way to have a conversation about oxygen, in occlusion? So, if you will follow this along, my presentation to you is that we're switching the conversation to muscles, away from gingival display and tooth position. Not that those things aren't important, but we're just complementing that. And I don't know about you, but it's hard to get a device like this in the ops, right? So it's hard for us to measure oxygen very well in the ops, right? So muscles, again, this is my intake, my sort of spin on this, my way of understanding it in my own mind. Muscles are a surrogate for measuring oxygen. Of course, muscles burn, besides sugar, they require oxygen. And that is the key tenet of neuromuscular dentistry. So that's now we're switching to neuromuscular approaches, and muscles are at the very top of this triad. Not that joints aren't important, they are. Teeth are important, but muscles are at the top of this triad, and that's sort of the formula for neuromuscular dentistry. Now, you probably heard some crazy things about neuromuscular dentistry, right? We all have. And I recently bought a truck, bought a Ford F-150. I did my research. I said, well, what do I need? I need a truck. And I went through all the pros and cons, and I ended up with buying a Ford F-150 truck. Well, I assure you, I didn't base my truck decision. I didn't go back and research the life of, Henry Ford. I didn't say, what was Henry Ford like? I didn't factor that into my discussion. I looked at the merits of the truck, and I bought a Ford. So I encourage you, despite what you may have heard about the different personalities and everything else at LVI or neuromuscular, focus on the merits of the program, not the personalities. So, yeah, I went to LBI. I went through the entire core program. They do provide a very good structured chronological sequence of programs. So let's get into some of the teeth, some of the things we like, and let's get into some clinical examples. So in my practice, I started my clinical practice 10 years ago from scratch, a biological dentist. I came here in 2005, was my first meeting. I became accredited in 2005, and I learned things that I didn't know how to do before. I learned how to, successfully remove amalgam and mercury safely. I was thrilled to have these skills, which I didn't have before. So what did I do? I went and started using them, right? I opened up my practice. This is a typical biological patient in the early days of my practice. We all see this in our practices. Many mercury fillings, number of root canals, and treatment plan is, revision and completion and so on and so forth. And so I did what I knew for them, and that was great. As the treatment progressed, as many of these patients do, of course, they want their teeth out. And let's say the root canals were removed and their questionable teeth didn't survive. We ended up with missing teeth. He already came in with missing teeth and he had more. So I did what I knew, which at the time was sinus lifts, implants, and I knew how to do that, so I did it, and I restored the upper dentition, and I placed the implants on the lower. I was just about to restore the lower implants, and I was thinking inclusion. I was on my pilgrimage, and I thought, well, if I go ahead and just restore these lower, these lower implants, what kind of bite am I putting him into? So let me introduce this for those who are not familiar. This is an EMG. Many of you will be familiar with this, many of you not, but very briefly, these are sensors that we put on the muscles of mastication, and we're able to see what a person's muscles are doing when they put their teeth together. When they clench, when they put their teeth together, when they're not clenching, when they're just sitting there like this. What are their muscles doing? The top two, this is the left anterior temporalis, the right anterior temporalis, left masseter, right masseter. Can you guys see okay? And when he put his teeth together, just gentle, this is what happened. His two temporalises fired, and his masseters didn't do very much. And this is a very classic scene of when you have a bad bite, a misbalanced bite, the temporalises are doing the work, the masseters aren't. So the way I explain to my patients is this. I say, Mrs. Jones, the temporalis, these muscles here, they're like the steering wheel. When you want to drive home from my office today, you just want to put a little bit of force on your steering wheel this way, a little bit this way, just to guide your car home. The gas pedal, what you're going to push to get home is the steering, is what you're going to push to get home is the gas pedal, and these are these muscles here, your masseters. These are your big muscles. These are your chewing muscles. This is what you should be getting a lot of force from when you bite. You don't drive home pushing on your steering wheel like this. That's not how you can make the car go. So when our temporalises are doing the heavy lifting, these tiny muscles here in the front, the temporalis anterior. It is a positioning muscle, but it's not a primary elevating or primary masticating muscle. It only does that when the bite is not optimal. And the optimal bite, the optimal muscles should be the masseters when people are chewing. Okay, the biggest. I always say, I tell my patients, think of horses. Big masseters. That's what is to the power chewing. So when we see this, we know this is not a very good bite. So if I just put those implants on those put those crowns on the lower implants, this is the kind of bite that I'm locking him into. Let me also introduce to you this. This is a jaw tracking. So just not to get too into it, but as you can see, when the person bites into CO, this is their upper incisor, lower incisor, and so this is from sagittal view, this is from the frontal view, okay? So we're able to track the jaw as they open their mouth, move their jaw, left, right. So, left, open, close, anterior, vertical, right? Can you see that? Is that making sense? This is the incisor. So this is jaw tracking. And these numbers here, Okay, it's called a Shibashi number, but what these numbers represent is simply the measurement from the gingiva of the upper central to the lower central in CO. So when they put their teeth together, these numbers here are in millimeters, are that number from there to there. So when this patient put his back teeth together, the distance was 22.3 from there to there. Okay, is everybody with me? Just by way of introduction, we're going to be seeing a few of these, so I just wanted to introduce that. And so what I did was, I knew his original CO wasn't good, and so I tensed him. This is not a how-to lecture on neuromuscular, so I have to just go through this. So I tensed him, and I said, okay, Willem, just move your jaw a little forward. That's position 2, a little back, position 1. So I get the patient to move their jaw in space, and while they're doing that, I can track what their muscles are doing. So when I see the temporalis muscles become quiet in a position that's reasonable to restore, we say, that's where we want you. That's our starting point for our orthotic, for our treatment. And we'll see more examples of this. So we put him in an orthotic. I'm sorry I don't have pictures for that particular case. It was an old case. And when I went through the whole program, when I went through with his many months of orthotic treatment, this is what he looked like at the end. So before you saw, so at rest his temporalises were quiet, his masseters were quiet. That's nice. But this is the difference. When I got him to put his teeth together, his temporalises were, again, essentially not doing any more work when he bit than when he was at rest. And this is a really good end goal for us. And then what we do want to see is we do want to see the masseters participate now in the bite. Okay, so very kind of generally and briefly, this is a good end goal for neuromuscular rehabilitation. When we see this in the orthotic phase, when we get to that point, we call it graduation. So now you're ready to graduate from your, temporary teeth into real teeth, and then we build it in porcelain. Okay, so that's pretty simple, and this is the final rehabilitation with those lower crowns in that bite that you saw earlier, with his temporalis quiet and his masseters participating. He didn't want anything cosmetically done with his front teeth, so we did our best to give him a natural look with the restorations to his own dentition. So here we have another typical biological dental patient. Again, I come back from IAOMT, I'm accredited, I know what to do here. I see mercury, I know what to do. I went through it and I did it. I took out his mercury using everything I'd learned here in the academy. I was thrilled to do that, I still am. And did what we needed to do. And I did see this. Obviously, I saw the wear, on day 1 when I saw him, but he didn't have symptoms. He didn't have headaches. He wasn't breaking teeth left, right, and center. So, he was asymptomatic. So we just did his mercury treatments and so on. Years go by, 10 years go by, and I start, this is what I see. Really, I realized, look, I'm actually probably just watching his deterioration. I just felt as I'm watching his deterioration. There were a lot of, these abfractions, fillings that were breaking down. I didn't do these, but everything was breaking down, and he's a salesman, so he's always on the road. He doesn't have his hygiene tools with him. He's going to have bad hygiene throughout all the slides you're going to see, but you can see he does, I shouldn't say bad hygiene, he has actually pretty decent hygiene. He just doesn't keep his aides with him all the time. So this is Ron, and I was always concerned with his posture. So I said, Ron, I think you're breaking down your teeth. I'm concerned about your bite. And we went through. This is his habitual posture, so the same as before. When he was at rest, just sitting there with his teeth open, the way you have your teeth open now, hopefully you're not clenching at this presentation. His temporalises were, a little bit higher than normal. His masseters were relatively quiet. When I asked him to put his teeth together gently, what we see, and what you're going to see now happen all the time, is that his temporalises were doing all the work, and his masseters weren't. This was in his habitual posture, okay? He had a kind of a slump, not very good posture. So then what we do is, for patients like that, we say, okay, that's fine. Then we work on their posture. So they're sitting on a ball. ball chair, like the ones at the gym. We do all the bites on a ball chair so that we can eliminate any compensations. They're standing kind of on their own without shoes and so on. And I said, okay, let's see what happened. The muscles got worse. When I fixed his posture and got him to, breathe in and just kind of hold his posture a little better, his muscles got worse. Why did his muscles get worse when his posture got better? His muscles got worse when his posture got better precisely because it takes, more energy, right, to have a good posture when you have a bad bite or when you have other things going on. It takes more work. It's easier to slack. It's easier. So when you force somebody to sit in a better posture, everything needs to be aligned better. Their muscles need to work harder. Because they need to work harder, they slouch. So they don't have to work harder. It's precisely for that reason that they would slouch so much. So, same thing. I said, okay, Ron, let's do your jaw tracking. And so again, you can see here, I asked that, hey, Ron, so open for me. And all the time he's opening, move your jaw, a little bit left, a little bit right, a little bit forward. And at each position, I could see different muscle readings, what his jaws were doing. And I said, okay, which one's the best one? I pick one, and that's the orthotic that we start in. That's the starting point. Okay, it's not the end point, it's the starting point. But notice this. I have no reservations about opening him from 15.9 up to 18.9, 3-4 millimeters. No problem. But look at how much delicacy there was between just anterior position. This is anterior, posterior, right? In the sagittal view. This is the back of the mouth. This is the front. Look how this one square is 1 millimeter. So there was enough difference just going anterior posterior to his muscles that it warranted me taking different readings. But vertical, no problem. Vertical, I could open them up like so we find a good posture, good bite for him, and this is his orthotic. So he wears this for a period of several months. We go through tensing and adjusting. His jaw begins to find a physiologically comfortable position. He'll see other practitioners along the way as needed. So remember, this is where he was before we started, and this is him at the end of what we call phase 1. So here, his muscles, even at rest, his muscles before we get started could not rest. Now, at rest, when his teeth were just apart normally, his muscles could rest. And very importantly, when he puts his teeth together, his temporalis were doing all the work. But now with the orthotic, again, his temporalis are doing almost no more work than when he's resting. What is doing the work are the masseters. And I'm not too worried about the discrepancy here. This is just plastic. He'll have real teeth and porcelain, which will be more balanced. But the point is that we want to see the temporalis is quiet and the masseters participating. When we see that, we say, Ron, you're ready. You're ready for your real teeth. So he goes from there to there, from here to here, and this is EMAX. We talked about, SPEAR. There's a big emphasis on using a particular material for a particular wear pattern. In neuromuscular, there is no such correlation. We don't use zirconia in the back to protect from breaking. I only use EMAX on all these worn down cases, so there's no matching of material to wear in neuromuscular, so that's an important difference. So, I propose oxygen is the king nutrient, and then from 6 months he went from there to there in his posture. It's not perfect, but we can see that from the distance from the back of his head to his back, this distance has closed significantly. He's not posturing. This is because we put him in a good posture, give him a good bite in a good posture, and then his body began to physiologically adapt to that better, to that new improved posture. And if he goes into a bad posture with the bite that we give him, he'll know it. He'll be like, something's not right, and he'll correct. Another key difference with neuromuscular is, anterior, posterior trumps vertical. Traditionally in occlusion, there's a big emphasis on vertical dimension. We saw that in the other centric, joint and teeth centric philosophies. In neuromuscular, there is not a big emphasis on vertical. There's a big emphasis on anterior posterior. So this gentleman had, I can see he's severely worn down his teeth. And we go through the same process, find a good starting position for him. These are his starting temps, upper and lower. He's in mid-treatment right now. But I just wanted to show you that in one appointment, we took him from here to here, and that was an increase of 10 millimeters vertical. 10 millimeters vertical is considered, kind of like heresy, right? So I said, well, people aren't going to believe me, so let me just film him. And so let's just play a little clip here for you. I was having a little bit of audio-visual difficulty with this, so you can turn this up for me, please. This is Dan. Good morning, Dan. So I just want to have a quick video with you today. We talked about, we opened up your bite about 10 millimeters. You were super overclosed. You couldn't see your bottom teeth. We've opened your bite up to 10 millimeters in one shot, basically. Tell me what kind of, have you had strange and weird, what kind of jaw problems have you had? Have you had jaw dislocations? Have you had like major convulsions of your jaw, or
no, I've had no adverse effects from having the jaw moved.
Okay.
So I have to say there's nothing that I would have to.
So we opened your
no complaints.
In 10 millimeters, we opened you up 1 centimeter in one shot. You haven't had headaches, migraines, your jaw isn't deranged or popping or nothing.
None of that.
None of that stuff. You're eating okay?
Yes.
Thank you. Okay, so I don't know about you, but kind of when I was in dental school, I was taught that if you opened up somebody 10 millimeters in one shot, their brain might start leaking fluid or something might happen. And so those things don't happen. All right, so how are we going to restore this case? Interestingly, this patient came to see me several years ago, and I knew he had a problem. I just knew I couldn't fix it. And so I said, look, I don't know how to fix your problem. I know you have a problem. I don't know how to fix it. But I was currently going through my training. And during that time, he went to see another dentist. And the other dentist is a friend of mine. Said he was going to fix his bite. And he was going to do all zirconia crowns, top and bottom, all zirconia. Because his solution was basically tooth material. His tooth material was going to be the way my friend wanted to essentially solve this problem, give him teeth that wouldn't break. But in my experience, what happens is when you use really, really hard substances and hard, materials, gold, zirconia that don't break, but there's an underlying problem, is you won't break the restoration, but you'll break the tooth under the restoration. What that looks like is an abscess. So, something's sore here. Nothing's broken, but you've broken the tooth underneath of it in the weight of the occlusion, which is if you just pounded the tooth into submission. So, how are we going to restore this case? Same as always. This was his resting, resting readings. He couldn't rest, and when we put his teeth together, it got even worse. Again, his masseters were hardly participating. Okay, same thing. We put his jaw. He was very, very overclosed, 11.8. No problem opening him up here, finding different positions, whichever one give him the best muscle readings. That position, we put him in the orthotic, and if you're interested to see what happened here, this was a cytoplast membrane, titanium cytoplast membrane. I had a lot of complications with this. 1 year I was doing a lot of these GBRs, so if anybody's got any questions about that, don't use that. That's a terrible material. And so went through the whole program with him, and at the end, this was his resting position. This was still high, but what I realized was he had a funny right eye, like he had this right eyebrow. We listened to the temporalis right here, but the sensor's here, and so he always I can't do it with my right eyebrow, but he kind of had his eyebrow up all the time, or half all the time, so I was getting readings from that. I realized that frustrated me for a long time. And then, put his teeth together, you can see all the temporalis is doing all the work, and when we do find a good bite, his temporalis are quiet and his masseters are doing all the work, then we say you graduated. Now you get real teeth. Thank you. So again, material choices, we go from here to here, and it's all Emax. There are no zirconia in here, and I'm sure this will last and will not break down. So it goes from here to here. Okay, so another interesting thing with, that we've been taught in articulator-based dentistry is that 1 millimeter of opening in the posterior will give us 2 millimeters opening in the anterior, right? We've all heard this. This makes sense when you think about an articulator, because if you open up 1 millimeter here, sure, you're going to get 2 millimeters opening here. We've all heard this, and this has been what we've been taught. This is a patient that second molars were cold and pressure sensitive. This one has, I have a temporary crown on this one, and this one was a big old composite. She came to me, these were her chief complaints, and I said, so what are the treatment options? You have a cracked tooth here, both these teeth are cracked. What would you like to do? We can do some of the following. We can do root canals. Of course, we can put crowns on them and see how it goes, then do root canals later. We can even remove the teeth. And if you don't want to do root canals, we can remove those teeth. So those are some of the present options. And the final option I gave her was, well, I said, you actually have posterior bite collapse. You've broken these teeth down, and you're just really compressed here, and there's undue pressure on these back teeth. And my fear is that if I just do a crown on here or a root canal on here, you'll get out of pain. But then 5 years later, you'll be like, doc, this one's kind of sore, and this one's kind of sore. And then I'll do the same thing here. I'll root canal this one, or crown this one, or pull it. And then 5 years later, well, this one's kind of sore. Because as I continue to work on those back teeth, I'm just, I'm just passing the buck along, essentially. I'm moving the pressure along. I'm posterior collapsing her along the way here. Because it's very easy to lose posterior dimension when you crown a tooth. That's actually one of the easiest things we can do as dentists. So she decided that the rehabilitation of her bite made sense. You can see how short the second molars were here, especially on the left side, very, very short here. She also was missing a lateral. She had a canine here, and so she didn't like the aesthetics of that, so we did some aesthetics work for her. So this is her before. Same as always, we went through. Now pay particular attention to this. When she closed down, she was at 18.5. Okay, her distance from the gingiva up here to here was 18.5. Put on the orthotics, we have to be very, very careful because it's very easy to give her too long, and she had very, very high, she had very long showing teeth here. And we went and we rehabilitated her, found good happy muscles, and restored her. This was the canine, and we tried to make it look like a lateral, try to make this look like a canine. What I want to show here is that this is her finished case. In the anterior, she was 20.5. She started at 18.5, and she ended at 20.5. So 2 millimeters in the anterior equals what in the posterior? 1 millimeter, right? Well, you tell me how much she was opened in the posterior. How much would you say she's been opened here? How much would you say she's been opened here? At least, it's way over 1, so it's probably 2 millimeters, maybe a little over 2, but she's definitely open, a good 2 millimeters here in the posterior, but only open 2 millimeters in the anterior. How do you do that? How is that possible? It's possible because with neuromuscular dentistry, we're relaxing many of the muscles, especially the temporalis, and the back end of the mandible drops. You're able to cause release, and you're able to create more space in the posterior without opening up the anterior in that 1 to 2 ratio. You open it up some, but you're able to break that rule. And so there, we opened it up 2 millimeters in the interior, and at least 2 millimeters, I would say, in the posterior. And these are Emax restorations. So we also heard that anterior guidance is the key to occlusal stability with Dawson, and this is a restored case, and this is bite. This is a bite adjustment after the rehab in chewing and in centric. So it's not just up and down, CO, tap, 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 but it's also, we give them a piece of gum and get them to chew. So these are excursions. So first of all, we see that other than a little, mark here, which is probably not a contact at all, there is no contact in the anterior in neuromuscular dentistry. So anterior teeth in neuromuscular dentistry are not the key to stability at all. We don't want any contact on the anterior teeth. The only time anterior teeth should contact is when you're biting something. when you're incising with your teeth. Otherwise, they're not to participate in occlusion. The whole idea of canine guidance to minimize muscle forces and minimize pressure in breaking teeth is already addressed with neuromuscular dentistry in other ways, as we've talked about. Okay, and it's a lingualized occlusion essentially at the end of the day. Another interesting case that I want to show you was this patient had chronic left side musculoskeletal symptoms. We can see, so left side, back of the neck, back of the head, shoulders, always left side. She had done everything in the world, including seeing other neuromuscular dentists for appliance therapy. And what we can see is the left maxilla is, canted. It's considerably, higher. And when we look at the wax up, right, we can see that the left side teeth, when we do a rehab, the left side teeth are significantly higher than the right side. This is intentional, and this is good, because her left side of her maxilla was high, and her muscles and because the left side of her maxilla was up here, I'm exaggerating, her mandible on the left side always had to travel extra high to make contact. So her muscles on the left side were always going to be, by necessity, more tight. And so when I was working her case up and I had her in orthotics, she always told me, I'm high on the left side. And I said, okay, that's fine. Let me check the right side. If I could not pull shim stock on the right, means she was occluding on the right, she was feeling she was high on the left. Why? Because her muscles are chronically tight from decades of this. So I said, you're fine. We leave it because what? Your muscles are stretching. So months and months of stretching is necessary for the patient not to feel that tightness anymore. You're literally tight, we're loosening that muscle. So we're using muscles to treat skeletal problems. Of course, surgery is an option. We could have, fractured her maxilla and brought it down, but that wasn't an option she was interested in. You can see there was a big, some kind of a skeletal, disruptance in her maxilla at some stage in her growth. How different her left side is than her right side, and so we rehabilitated her case here. The left side teeth are longer to compensate for the skeletal discrepancy. These are long teeth, but this is her smile. So the perception that, with neuromuscular, you're going to give everybody really long teeth doesn't actually hold, because you can usually do it on the lower and hide it. Does the balance last? Well, this is a 4-year follow-up. This is a gentleman that we saw, and you can see before he had lots of wear on his anterior teeth and bicuspid drop-off, and this is a 4-year follow-up. These restorations were done in EMAX. The only one that really has any wear is this particular central, and I did this myself at the time of insertion. It was just high, so I inserted that. I did this myself with a diamond burr on the day of insertion. Otherwise, things are still intact. So he was breaking down his enamel with bad muscles, but he was having stability in EMAX when his muscles were balanced. So, in summary, in the Dawson-Pankey model, it's a lot of emphasis on condyle to teeth. We've seen that. In SPEAR, we sort of move more specifics now. We look at intraoral damage, the diagnosis. This is a big part of SPEAR. In POISE, we start shifting the conversation outside the mouth. We talk about deprogramming. And finally, in a neuromuscular-based philosophy, the discussion is, not that we ignore all these things, we don't incorporate them, but now we're discussing oxygen, muscles, and posture. Again, I have no financial interest in this, but I did arrange for anybody who's interested to see what this is about. You can call them and get $500 off your first course. Just mention the code IAOMT. Very briefly about mentorship. We all go to CE courses, and as I've learned over the years, we just think that as dentists, we're sort of we're inculcated into thinking that we just need to know how to do something. If we learn how to do something, then we'll just be able to do it to our heart's content, and our practices will be great, and everything will be great. Well, if that was the case, I know how to do a crown, or you know how to do a crown. So my question is, are you doing all the crowns you want to do in your practice? You know how to do it. So if you know how to do it, how come you're not doing all the crowns you would like to do in your practice? Because of course there are many more things than besides how to, but that's what we've been taught as dentists. So mentorship gives us the how to outside the mouth, not only inside the mouth, but outside the mouth. I was thinking about the pinhole technique. It's very, very in mode, and so you can pay your money, sign up, go learn how to do pinhole technique. Once you learn how to do it, you're going to need to know a heck of a lot more than that has to be in place so that you can do a lot of them in your office, right? Your whole team needs to know what's going on. You need to understand the admin and clinical protocols. There's just so much more you need to know to implement and do a lot of pinhole technique other than the actual how to do the procedure. If you want to do a lot of pinhole technique, I'm just using that as an example. And so this type of dentistry, rehabilitative reconstructive dentistry, of course, the patient needs are well above $5,000. And so if you want to do cases like that, you're going to need a lot of pieces outside of the how-to. And that's where mentorship comes in, whether it's with me or somebody else. I would advise everybody to seek a mentor. And the mentor that you're looking for has to be the one that's already doing what you want to do. Right, that's like the basic thing. So, in my practice, my practice is limited to comprehensive adult dentistry with a biological, obviously, field. So, that's what I do. If you're interested to do that, I'd be happy to help you get to the next level, whatever that next level is for you. Thank you for your attention, and I'll be here for questions. Thank you. Thanks, Chief.